Okay. Before we start getting into the content, this is something that I really love to talk about is EMGs and electrodiagnostic tests. Kind of what I've tried to do with this, I know there's learners of several different levels in the room. So I've tried to go through some basic things for people who maybe don't have as much experience thinking about and interpreting electrodiagnostic tests, and maybe put some pearls in there for those of you who have a little bit more experience with this. So first we'll go through some terminology just to make sure we're all on the same page and talking about the same things. We'll talk about some different electrodiagnostic testing principles, kind of some fundamentals of the tests that really help you interpret it. And then we'll go through a couple cases at the end, including some kind of common pitfalls that I see. So nerve conduction studies, or NCS, refers to the motor and sensory nerve responses for the most part. EMG actually technically just means the needle study. Now, we often interchangeably use EMG to really mean electrodiagnostic study. The electrodiagnostic study means nerve conduction studies plus EMG, but you'll probably hear me throughout the talk use the term EMG to really refer to an electrodiagnostic study. The SNAPs, or sensory nerve action potentials, those are the sensory responses that we're obtaining when we stimulate sensory nerves on the nerve conduction studies. CMAPs are compound muscle action potentials. Those are the motor responses that we're eliciting on our nerve conduction studies when we're stimulating motor nerves. And then motor unit action potentials are what we're evaluating on the needle study or EMG portion of the test. So I think just a couple of principles. First is that the EMG is really an extension of the history and physical exam. You really have to understand or have a sense as to what you're looking for before you order an EMG test. And I will tell you, if you have a sense as to what you're looking for when you're ordering it and you actually alert the electromyographer to that, I think it really helps them, and I think it also improves the quality of your report. So the more specific that you can be in terms of what diagnosis you're specifically wondering about, I think the report you're going to get back is going to be that much more helpful to you. It's individualized based on the patient's symptoms, usually some degree of history and exam. Again, we want to know what we're looking for before we go looking for it. And EMG is not really a fishing expedition. It's modifiable in real time, so as we learn more on the nerve conduction studies or needle exam, we can kind of change what we do. I also think it's important to understand that an EMG really isn't, or an electrodiagnostic test isn't an objective test. Nerve conduction studies are very technically challenging, and the needle exam is really semi-quantitative. So really the quality of the data that you get on an EMG test really depends on the experience and the skill of the person that's doing it. It's not a perfectly objective test. So what are we trying to do, or what are we trying to accomplish with our electrodiagnostic testing? First one is localization. And I think that's the most important, right? If a patient has numbness on the fourth and fifth digit, could that be a median at the wrist, or sorry, an ulnar neuropathy at the wrist? Could that be an ulnar neuropathy at the elbow? Could that be something more proximal, like a lower trunk or medial cord plexopathy? Could that be a C8 radiculopathy? That's a great question that you're going to be able to answer on an electrodiagnostic test. Oftentimes it can provide some additional information about the underlying pathology. Is the neuropathy axonal? Is it more demyelinating? It can define a temporal course, although I think asking the patient a couple questions can really accomplish that same task. And then really it can kind of guide subsequent testing and evaluation. But really what we're trying to do first on the EMG is really localize the problem. Because if we don't know where the problem is, it's going to be really difficult to figure out what is going on. In terms of tests that I think of as being very high yield that we see in the lab, one, if a patient has objective weakness, and that objective weakness is accompanied by lower motor neuron signs, areflexia, fasciculations, muscle atrophy. Usually we're going to get some really helpful information from the EMG test. Or if they have objective weakness, lower motor neuron signs, and a lot of large fiber sensory loss, so vibration and proprioceptive sensory loss. Patients who have atypical neuropathies, so not sort of your standard distal symmetric polyneuropathy that you can see in diabetes, but neuropathies that have atypical features, so ones that are acute or subacute in onset, ones that are non-length dependent, motor predominant, or where there's a severe amount of large fiber sensory loss, like in patients who have sensory ataxia or pseudoathetosis. Electrodiagnostic studies in these settings are really, really helpful. Because the the study is going to tell you what type of neuropathy that you're dealing with, and that might actually help really shrink your differential and really guide subsequent evaluation. Electrodiagnostic studies are really helpful for myopathy, especially if you're concerned for a myotonic disorder and looking for myotonic discharges. Again, that might help you in terms of narrowing your differential. They can also help you assess what might be a good muscle for biopsy. So the needle study can tell you what muscle is potentially affected and might be a good target. Also very helpful for compressive neuropathies, kind of telling you, that it's present, also sort of giving you a degree of severity as well. What are some tests that I think are a little bit lower yield? I think this is an important point to make, right? Because electrodiagnostic studies are expensive, they're painful, and we know there was a great article in the Green Journal that looked at patient out-of-pocket costs for tests like EMGs, like MRIs, and not surprisingly, they're going up. Patients are having to pay a lot out of pocket for these tests. So you want to make sure that you're being cognizant of not only medical resources, I think, but the patient's financial resources as well. So when a patient has pain in a normal neurologic exam, there have been some good retrospective studies that have shown that they only have EMG findings about 1/3 of the time. Most of the time, that's actually compressive neuropathies. In one study that actually looked at patients with pain and focal tenderness who were sent for electrodiagnostic studies, they were never positive. So if pain is the only thing, I would maybe think about something, a different test first. In patients who have distal symmetric polyneuropathy, so that's a diabetic patient who has burning pain in their feet and some distal sensory loss, I don't actually think electrodiagnostic testing is very helpful. It may be abnormal. In many cases, it's normal because most of those distal symmetric polyneuropathies start off as small fiber predominant. Remember, on an EMG, we're really only testing large myelinated fibers. So if you have a process that's mainly affecting small sensory fibers, your EMG test is going to be normal. One reason that I see people order electrodiagnostic studies for distal symmetric polyneuropathy is because they want to rule out a demyelinating neuropathy. But in patients who present with this phenotype, distal symmetric sensory predominant polyneuropathy, they almost never have a demyelinating neuropathy. So most of the time, if the EMG is abnormal in this setting, you see some axon loss, maybe the sensory amplitudes are a little low, but it doesn't actually really give you much in terms of additional information about the etiology. So especially in patients who have clear risk factors for distal symmetric polyneuropathy, I don't think the electrodiagnostic study really yields a whole lot. Also in patients who have radiculopathy with pain or only sensory symptoms, the EMG or the electrodiagnostic study wouldn't probably be my first test that I order. And the reason is, we kind of have to review a little bit of the anatomy of the sensory nerve. Remember, the sensory nerve is a bipolar nerve. Its cell body is here in the dorsal root ganglia. It has a proximal axon that connects the dorsal root ganglia to the spinal cord, and a distal axon that connects the dorsal root ganglia to whatever the sensory receptor is. In processes that affect just the proximal axon here, as in this case, the distal axon, which is the one that we test on our nerve conduction studies, that's what's generating our sensory nerve action potentials, is still connected to its cell body, and so it remains intact. Now, this patient will still have numbness, right? The sensory information isn't getting to the spinal cord and then to the brain, but when you check a sensory nerve action potential, it will be normal. So if you have a radiculopathy that's just affecting the sensory root, the patient just has pain or just has sensory loss, and it doesn't affect the motor root, your EMG test is actually going to be normal. As opposed to processes that affect the dorsal root ganglia or the axon distal to that, you will have axonal degeneration, Wallerian degeneration, and your snaps will be abnormal. And that's why sensory nerve action potentials, or SNAPs, are so helpful in terms of localization. If you have a patient who says they have numbness in a particular distribution, you want to make sure that you're ordering an EMG or you're asking for an EMG that actually looks at a sensory nerve action potential in that distribution. Because if it's abnormal, then it tells you there must be something at or distal to the dorsal root ganglia that's going on. If the SNAP is normal, then it's telling you, okay, the pathology must be proximal to the dorsal root ganglia. So the SNAPs have a very important function in terms of localization. So this is kind of a typical setup for a sensory study. where we have a proximal stimulation and distal recording in the first digit, so this is a median sensory response. Typically, the information that you're going to get on a sensory nerve conduction study is amplitude, which reflects the number of axons that are depolarizing under the recording electrode, and then we'll get a latency as well, and typically that's a peak latency that kind of reflects the speed of conduction. Most of the time, the distances that we use on these tests are relatively standardized, and then we have some normal values on amplitude and latency. So just a couple important points about sensory nerve conduction studies, and I think we've hit on these. Remember, these only measure large myelinated fibers, so if you have concern for a small fiber predominant neuropathy, probably EMG is not the first test to do. You might want to think about other tests that actually can assess the function of the small nerve fibers, like a skin biopsy. And again, sensory nerve conduction studies are normal in a radiculopathy because the process is proximal to the dorsal root ganglia. Motor studies are a little bit more complicated, and that's because there are two stimulation sites that are required, and we'll kind of talk about why that is. So we get two amplitudes. We get a distal amplitude and a proximal amplitude. We get a distal motor latency, and that's typically standardized. We have sort of a normal value for the distal motor latency, and then we get a proximal motor latency. Depending on the length of somebody's arm, that proximal motor latency can change. So that's not a set value, but we use the proximal motor latency to actually calculate a conduction velocity, and that's something that is very conserved between individuals. So again, just like the sensory nerve action potentials, the amplitude usually reflects either the number of motor axons that are present or also the number of muscle fibers that are present too. So processes that pick off muscle fibers like myopathy can sometimes cause your motor amplitude to drop. The distal motor latency reflects the speed of the fastest conducting fibers, as does the conduction velocity. So the reason why we need two stimulation sites to calculate a conduction velocity is because that distal motor latency, not only does it include the action potential that traveled down the nerve, but it also includes time of coupling across the neuromuscular junction, depolarization of the muscle fiber. So there's a lot in that distal motor latency that isn't just how fast the action potential is moving down the nerve. So what we do is a proximal stimulation, and then we can subtract the distal motor latency from the proximal motor latency, and what we get is the time of conduction across D there. And if you know the distance between the distal and the proximal stimulation site, you can get distance over time. But that's why there's always two stimulation sites for motor studies that you'll see on your reports. So in axon loss neuropathies, the hallmark is a reduction in the amplitude. It's important to know that if there is especially severe axon loss, where you're losing the fastest conducting fibers, you may see some mild velocity changes. Typically, though, those velocity changes should never fall more than 70%, the lower limit of normal. For that same reason, you can also see some mild distal latency prolongation as well. Again, this is often seen in very severe axon loss processes. It doesn't necessarily mean there's demyelination there. It just reflects dropout of the fastest conducting fibers. Demyelinating neuropathies, conversely, what you'll see is the conduction velocity is slowed and it's less than 70% the lower limit of normal. So typically in the upper extremity, that's conduction velocities of less than 34, 35. In the lower extremity, that's conduction velocities of less than 28 meters per second. And their distal motor latency is significantly prolonged, usually more than 130 and often more than 150% the upper limit of normal. Amplitudes may be normal or low. Oftentimes in demyelinating neuropathies, there is axon loss as well, so it's not unusual to see amplitude drops. And then conduction block is another important finding that usually signifies that somebody has an acquired neuropathy that's demyelinating. So conduction block, yeah, of course.
Maybe you're going to show this, but could you discuss timing of the nerve conduction studies relative to the symptoms?
Sure. I wasn't going to discuss that in detail, but that's a good question. So the question was timing of nerve conduction studies in relation to symptoms. So most of the time and this really becomes relevant when patients have acute onset neuropathies like Guillain-Barré. Most of the time, by the time the patient arrives to the EMG lab, they've had symptoms of their neuropathy for a long time. But sometimes in GBS or other acute onset neuropathies, that might not be the case. A lot of times these findings, not only demyelinating findings, but also amplitude changes in somebody who has an axon loss process, does take some time to show up. And that's because after you've transected an axon, Wallerian degeneration isn't immediate. It does take some time to develop. So, kind of the common teaching is that with symptom onset, you should probably wait at least 3 weeks before doing nerve conduction studies, because if you're doing it before then, you may falsely conclude that there are some normal findings. So it does take a number of weeks for these findings to develop. And again, this becomes most relevant for acute onset neuropathies. But you might also think about that in a patient who you think maybe has developed an acute radiculopathy as well. So conduction block is another important finding that signifies that a patient has a demyelinating neuropathy. So in the normal circumstance, in this figure above, both the distal stimulation and the proximal stimulation, the waveforms look about the same. And that's because the conduction down the various motor nerves is relatively uniform. Most of them have a similar conduction velocity. If you have an acquired demyelinating process, though, that's kind of causing patchy demyelination, some nerve fibers are demyelinated more than others, you're going to have a greater dispersion of conduction velocities. Some may be conducting relatively normal, some may be very slow. And now with these proximal stimulations, the response is going to arrive at the recording electrode at much different times. So the response is going to be much more spread out, and you'll see the amplitude drop. Maybe if you have a nerve that's very demyelinated, it's not actually even going to be able to carry the action potential distally. And so you'll see a drop in that proximal amplitude. Any drop of 50% or more is sort of considered unequivocal conduction block. Drops of 20%, 30%, 40% we might consider partial conduction block. So that leads me to a couple of cases, and I think there are some really high yield teaching points in these, kind of, which is why I wanted to bring them up. So these are both patients I have seen in the last few years. The first one is a 60-year-old female. She has well-controlled diabetes. She has a history of a lumbar fusion, and she presents with progressive weakness and pain. Her initial diagnosis was CIDP, and that's why she was referred to me. So kind of going through her story, she said about 3 or 4 months ago, she developed some radiating low back pain and also some distal numbness at about that same time. The numbness progressed, but it was always worse on the left side. And then over time, her left leg started to give out with walking. And then in the past few weeks, she's lost the ability to ambulate. She has noticed some muscle atrophy, especially in the left thigh. She does have a little bit of numbness in the hands, but really plays down the symptoms and says it's really about my legs. In terms of different testing that she had, so she had an EMG, and the interpretation was severe axonal and demyelinating neuropathy of symmetrical fashion. She had some imaging looking for radiculopathy that was negative. She had CSF testing with a protein of 65. I actually want to make a comment on CSF protein. So actually in our lab and most labs around the country, a normal CSF protein is like 45. The normal level is 45 if you're 19. The normal level is 45 if you're 119. And that's probably not accurate. Protein levels increase as you age. So in somebody who's over 60 years old, probably a normal protein level is 60 or so. Kind of another rough estimate that I've sort of been given by some of my mentors is like once you're over 60, like age minus 10 is a reasonable cutoff for normal protein. But it's important to recognize that it does increase as you age. So I think because of this mild protein elevation and also the EMG, she was diagnosed with CIDP. She was treated with IVIG. Later, mycophenolate mofetil was added. And her symptoms were really unchanged several months into treatment, and that's why she was seeking a second opinion. That's why she saw me. I wanted to bring up her initial EMG because there's a couple of things that I want to point out, and a couple of things that I really think everyone should be looking at on their reports to really understand, is this a quality report? Is this an interpretation that I can really trust? You'll notice most of the latencies, so these are motor nerve conduction studies, so median, ulnar, perineal, and tibial. Most of the latencies are prolonged. So the median distal latency is 4.6. Probably for somebody who's 60, that latency should be less than 4. For the ulnar nerve, it's 5.3. That normal latency should probably be closer to 3 milliseconds. And then for the tibial nerve, these latencies are almost 8 milliseconds. Normally it's 6 or less. So all of these distal motor latencies are mildly prolonged, and especially those tibial motor latencies, maybe that's approaching demyelinating range. One thing you'll notice, though, is missing from this report, and that's temperature. That is an important quality measure on EMGs because temperature can affect your conduction velocity and your latency. It can slow your conduction velocity, prolong your latency, and actually temperature increases your amplitude. So it's really hard to interpret these latencies without a temperature and really understand, is this a true finding or is this a product of a cold limb? You'll notice the perineal response at the EDB is absent on both sides. It looks a little asymmetric, though, at the tibial nerve. So the amplitude is 1.5 on the left and 4 on the right. All of these conduction velocities, I would say, are basically normal. So 50 in the arm and 30, 34 in the leg. None of these are in a demyelinating range. The other thing that I'll point out here is look at the motor response on the ulnar nerve in terms of the amplitude. The amplitude actually increases with proximal stimulation and then decreases again. And that's not what we see. Typically, when we're doing nerve conduction studies with proximal stimulations, it's normal to see a mild drop in the amplitude. It should never be more than 20 or 30% because then you're thinking conduction block. But amplitudes don't increase with proximal stimulations. So there's several things on these motor nerve conduction studies where you sort of wonder how much you can really trust the data. In terms of the sensory studies, maybe some non-length dependent findings. So this person had a sural sensory response of 6 and 7 on both sides. That's pretty robust for somebody who's 60 years old. Looks like there's some asymmetry in the superficial perineal sensory response where it's absent on the right, but the amplitude is 14 there on the left. The radial sensory response is normal. Median sensory response basically normal, and then the left ulnar sensory response is out. So just kind of this patchy absence of sensory responses that aren't really length dependent either. If you're affecting sensory responses in the upper extremity like the ulnar nerve, you really should be having significant changes in lower extremity sensory responses, and these surals I would say are basically normal for age. So a lot of this not really adding up. I also, so this was it in terms of the data that I got. There was no needle exam that was included, and that's one thing to sort of watch out for. If not all the data is included in a report, again, I think that's a really important quality measure. If there is an absence of temperature recording, that should also be sort of a red flag, especially if the diagnosis of a demyelinating neuropathy is being made based on mild latency prolongations, mild conduction velocity slowings. That could be a temperature effect. Or the other thing that I see very often is patients have very severe axon loss. Their latencies are a little long, their velocities are a little slow, and that's interpreted as a demyelinating neuropathy. So that's a very common mistake that I see. You know, in this case too, I would say the conclusion isn't really consistent with the clinical presentation. This was interpreted as a symmetric neuropathy, and this patient was presenting with a lot of asymmetric features. She was saying all her symptoms were worse on the left side. She was noticing thigh atrophy as well. The other red flag or kind of technical issue that I run into a lot is not correcting findings for age. So there are some very normal age-related changes that happen, especially with nerve conduction studies, and you have to take these into account when you're interpreting the data. So what are some of those changes? So you can sometimes see an absent or low perineal motor response at the extensor digitorum brevis. I see this a lot in people who are older than 50, but sometimes you can see it in people who are younger, especially if this is the only change that you're really noticing. The extensor digitorum brevis is an intrinsic foot muscle. It gets beat up a lot. Sometimes there can be local muscle trauma, and so the amplitude might be low. And if that's all you're seeing, usually doesn't have very much clinical significance. You can lose some of these responses, these other responses, as you age. So an absent medial plantar response can be normal in someone who's 50 or older. An absent superficial perineal sensory response can be normal in someone who's 60, 65. And then an absent sural sensory response can be seen in somebody over the age of 70, 75. So it's not unusual that I get referrals in patients who have a diagnosis of neuropathy. They're 78, their surals are present but low, and somebody interprets that as a neuropathy. So important to recognize that you can have some reductions in these, especially sensory responses as you age. So kind of back to the case, she continues to have pretty severe pain. Her numbness and weakness seems to be largely unchanged in the last several months, so it's kind of stabilized. It's not better, it's not worse. She also notes that at the start of her symptoms, she had about 20 pounds of weight loss and is noting some early satiety. You ask her about some different autonomic symptoms like constipation, difficulty starting a stream of urine, and yeah, she does endorse that. Not much orthostatic hypotension though. She says, other than mild numbness, no other significant upper extremity symptoms, but she has developed a band of numbness in her abdomen, sort of at the level of the umbilicus. In terms of her exam, I think she did have a little bit of trace intrinsic hand muscle weakness, but then she had pretty clear asymmetry on her exam. So she had proximal weakness on the left that was worse than the right, and then pretty severe distal weakness as well. She really had minimal dorsiflexion abilities bilaterally. Her reflexes were 2+ at the tricep, but otherwise absent. And then she had some large fiber sensory loss. And then in that area where she's noticing numbness, there is a reduction of pinprick sensation, kind of at about the T10 dermatome. So there's a few red flags in this case for CIDP. One is the prominence of pain. Do patients with CIDP have pain? Yes, they do, but it's often not the symptom that brings them in for evaluation. Usually they're noticing weakness, imbalance, incoordination, and pain is usually not the first symptom. So that's a little bit unusual. Asymmetry here is also unusual for CIDP. That tends to be relatively symmetric. There are asymmetric variants, but those are more likely to affect the arm. CIDP rarely has any overt clinical autonomic symptoms. So this patient is having some changes in bowel and bladder, early satiety, very unusual for CIDP. Also the involvement of maybe a thoracic nerve root. I think maybe that T10 dermatomal numbness could be a thoracic radiculopathy. That's pretty unusual for CIDP. And also she hasn't really responded to typical treatments that we use. So a lot of red flags that that's not the diagnosis. So when we repeated an EMG, here's kind of what we found. Sensory responses with the sural and superficial perineal were absent in the lower extremity. If you look at the median and ulnar sensory responses, these are low in amplitude, and the latency is mildly prolonged. But again, this isn't in a demyelinating range. This might just be a product of severe axon loss and dropout of the fastest conducting fibers. The radial sensory response is relatively normal. Kind of at the border. So this looks like actually relatively length-dependent sensory loss. And that's because our radial sensory response we're measuring usually at the anatomical snuff box compared to our ulnar and median sensory responses, which are digital sensory responses. So the radial sensory response is a little bit more proximal and typically the last to be affected in a length-dependent process. So I would say just based on based on the sensory nerve conduction studies, this kind of looks like length-dependent sensory axon loss. A little bit different story when it comes to the motors. So her distal motor amplitudes are pretty severely affected on both sides. Absent perineal motor response on the right, very low on the left. Kind of similar story with the tibial motor responses. But then really you see this clear asymmetry in her motor responses with proximal muscles. So the tibialis anterior and femoral motor response much lower in amplitude on the left than the right. So kind of corroborating her reports in your exam of some asymmetry. Again, some mild conduction velocity slowing in the leg, but not in a demyelinating range, and we're not really seeing latency prolongations in a demyelinating range. And then when it comes to her nerve conduction studies, so kind of positive sharp waves and fibrillations on the left-hand side of the panel, that's kind of the acute or ongoing findings. The changes in motor unit action potentials, I think of that as chronic. So I sort of subdivide this, this table into acute changes on the left, chronic changes on the right. And what we can see is that not only in distal muscles like tibialis anterior and tibialis posterior, as well as gastroc, we're seeing some active changes, but also in more proximal muscles too, like even a paraspinal muscle, we're seeing some active denervation. So clearly there's something going on that's very proximal here that has to be involving the motor roots as well. And then a lot of changes indicating reinnervation, which sort of makes sense. This has been going on for many months. So there are some reinnervation changes. Some of the units are increased in duration and amplitude, and they're more polyphasic. So the final diagnosis here was a diabetic radiculoplexus neuropathy. This patient had some EMG findings, electrodiagnostic findings of nerve root involvement, but there was also nerve involvement because her sensory responses were abnormal. And this is a pretty typical case for a radiculoplexus neuropathy. These are often, this condition is often heralded by a great deal of weight loss. That's a common history. Oftentimes pain is the first symptom, and then you get this progressive asymmetric proximal and distal weakness. There's often a lot of large fiber sensory loss as well, so oftentimes they have kind of a worsening generalized neuropathy in the context of this. Typically they progress for months, often take several months, 5 to 6 before they nadir. Usually they'll stabilize and there can be some spontaneous improvement over time. Autonomic involvement is pretty common, and you can see sometimes thoracic and cervical root involvement as well. And I think that's what we were seeing with that T10 dermatomal numbness, is maybe a little bit of thoracic root involvement. So this brings up an important point, and that's the misdiagnosis of CIDP. It's quite common. This was a great study in the Green Journal done several years ago. This was a single center study, and they found that almost 50% of patients referred to their center failed to meet even minimal CIDP diagnostic criteria. So I think it's important when you're thinking about a CIDP diagnosis that you're really referring to high quality criteria, and there are several of them out there before you're making the diagnosis. This is important because the average IVIG duration in these patients who didn't have CIDP was 18 months, and so that's a lot of medical dollars to waste on treatment that's not going to work for these patients. So a couple take-home points. CIDP is commonly misdiagnosed. Mild conduction velocity slowing and latency prolongation is common in the setting of severe axon loss. You can see mild latency prolongation in the context of a low limb temperature. And then, we kind of brought up some different red flags that you should be looking for on your reports that might lead to some spurious conclusions. Okay. My second case is a 57-year-old male who I saw for progressive weakness. He was referred for ALS. He had a pretty prolonged course. 3 or 4 years ago, he started to notice weakness in the hand, trouble holding a bowling ball. Rarely, he has a little bit of choking sensation when he tries to swallow. He has had some muscle atrophy in the distal arms, but no fasciculations. No real sensory symptoms, no other clear bulbar or ocular involvement. And I think what really led to his diagnosis was an EMG that he had that was interpreted as diffuse extensive denervation changes, worse distally than proximally, consistent with a severe generalized axonal motor neuron disease. In terms of his exam, he had normal cranial nerves, no fasciculations in the arm, but he did have some atrophy in both arms. His proximal strength was full in the upper extremities, but he did have some intrinsic hand muscle weakness and especially finger flexion weakness. And he did also have some asymmetric quadricep weakness as well. So a couple of red flags for an ALS diagnosis. This was slowly progressive, right? Most ALS patients have a 2 to 5 year life expectancy, and he's had symptoms for years and is still walking around, is really only mildly affected. He didn't have any upper motor neuron signs. He does have, kind of more generalized weakness, and then, pain or sensory symptoms would also be a red flag. He didn't have that. When you ask him to make a fist, this is what you see. So on the left, you can see he can bury his fingernails. On the right, though, you can see that he has trouble completely flexing the fingers. So in the interest of time, I'm going to jump ahead and just kind of skip over a couple slides. He had low motor amplitudes everywhere, And when you see low motor amplitudes throughout your nerve conduction studies, there's a couple things that you really should be thinking of. One would be potentially a motor neuron disease or a motor nerve disease. Neuromuscular junction diseases, classically Lambert-Eaton, can cause diffusely low motor amplitudes. But also remember, a distal myopathy that's picking off motor fibers can also cause diffusely low motor amplitudes as well. In many myopathies, right, because they're predominantly proximal, nerve conduction studies are normal. Most of our nerve conduction studies we're doing in distal hand and foot muscles. But if you have a myopathy that is affecting those distal muscles, it can affect the motor amplitude. And then polyradiculopathy would be another consideration as well. In terms of his needle study, he did have some positive sharp waves and fibrillations. So those large discharges are my needle movements. And now this is at rest. You can see positive fibs and or positive sharp waves and fibrillation potentials. So we did have some evidence of denervation. Normally we think of denervation as something that affects either the motor axon or the motor nerve. But remember, if you have a muscle disease that splits a muscle fiber because of necrosis, each muscle fiber only has one neuromuscular junction. And so if you have something that causes a lot of necrosis and fiber splitting, you can have positive sharp waves and fibrillations. So myopathies can cause positive sharp waves and fibrillations. And so I think that's what we were seeing in this case. You can see on his needle study that he had very sharp polyphasic short duration units. So this actually really looked more like a myopathy on his needle exam. He had some additional testing. His CK was mildly elevated. He also had these positive antibodies, NT5C1A. So his final diagnosis was IBM. So just in the last minute, a couple words on IBM. It's idiopathic inflammatory myopathy. It's seen almost exclusively in people who are older than 50, and it's the most common acquired myopathy in someone over the age of 50. It usually is slowly progressive and classically asymmetric. If you see someone, especially with deep finger flexion weakness and quad weakness, this is definitely something you want to have on your radar. Dysphagia is common. Their CK is often elevated, but usually minimally so, and can sometimes even be normal. So if you see someone with a CK of like 20,000, probably not IBM. You can see these specific antibodies in somewhere between a half to 2/3 of cases, and they typically don't respond to immunosuppression either. So just a couple take-home points from this case. Positive sharp waves and fibrillation potentials can be seen in myopathies where there's myofiber necrosis and splitting. Slowly progressive course in this case was a red flag for ALS, and IBM is the most common acquired myopathy in those over the age of 50. So just some final thoughts. EMG is semi-quantitative. The quality of the study is really dependent on the skill and experience of the electromyographer. For complex cases, I would always advocate for referral to specialists with fellowship or experience with these more complex cases. Make sure you're using criteria when you're defining demyelinating neuropathies, and then I think I want you all to feel empowered about going through your electrodiagnostic tests and looking for some of these red flags and maybe questioning some of the findings if you're seeing them. All right, I think that's all I had. Thank you.
We only have time for one question if someone wants to ask one, but otherwise write them down and we'll have a question and answer at the end.
Is there an association between inclusion body myositis and AIDS?
And AIDS?
AIDS.
Like HIV?
Yeah.
So there are some patients with an overlap of HIV and actually polymyositis that have been described. I'm not personally aware of an overlap between HIV and inclusion body myositis, though. There are rarely some types of lymphomas that have been described in IBM patients, and we don't really know what the connection is there. I believe they're kind of rare follicular type lymphomas that have been seen. Yeah, that's a good question. Our nerve, sorry, the question was, is there a weight limit for doing motor nerve conduction studies on femoral nerves? We'll attempt them on just about anybody. I actually don't find them to be that helpful. I mean, if there's a femoral neuropathy or some proximal process, usually I don't depend on the femoral nerve conduction studies to tell me that, because it's a deep nerve. You might not get a response in somebody depending on their body habitus. And so really it's going to be the needle exam looking at femoral innervated muscles that I think is going to be far more helpful than any femoral motor study. So I don't do them all that much because I just I don't really think it adds actually a whole lot of information. All right.